College. My name is Gina Fauzia. I welcome you today on guest lecture at Faculty of Medicine, Universitas Brawijaya. This morning, we are honored to host two internationally recognized experts in next-generation sequencing and diagnostic of hematopathology. The lectures you will hear today representing the cutting edge of clinical laboratory medicine for hematological malignancy. This knowledge will help inform patient stratification, treatment selection, and prognosis assessment. We would like to extend our gratitude to Professor Wisnu Barlianta, Pediatrics Consultant, as Dean of Faculty of Medicine, Universitas Brawijaya, for hosting this educational forum. Representing the Dean, it is my pleasure to invite Dr. Sadevi Nandan Kurniawan, Neurologist Consultant and Vice Dean of Faculty of Medicine, Universitas Brawijaya, to deliver the opening remarks. Please, Dr. Sadevi.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Good morning, ladies and gentlemen. Allow me to introduce myself. My name is Sadevi. As Vice Dean of Student Affairs. On behalf of the Faculty of Medicine, Universitas Brawijaya, and Dean Professor Wisnu, you cannot attend this morning. I'm great pleasure to welcome all of you in this guest lecture. A special welcome to Dr. Lee from National University of Singapore and National University Hospital. Also, Dr. Chen from Nano Biotechnology China. Thank you for coming here. And I would also like to warmly welcome to the chair and member of Indonesian Association of Clinical Pathologists, Malang branch, our professor, faculty member, medical specialist, resident, all participants joining us today. A very warm welcome to all of you. First, let us give thanks to the Almighty of God for the opportunity to gather here today for this guest lecture on the title Advancing Hematologic Diagnostic Through Flow Cytometry, Cytogenetic, Molecular Testing, and Next Generation Sequencing. We are pleased to have two guest speakers with us today, Dr. Lee and Dr. Chen. Thank you for being here and for taking the time to share your knowledge and experience with us. I would also like to thank the Department of Clinical Pathology and the Clinical Pathology Specialist of Universitas Brawijaya, PPDS Pathology Clinic, Malang, and everyone who has contributed to making this event possible. Having international experts with us today is also a valuable opportunity to broaden our perspective and strengthen academic connection. We hope this event will open the door to the future collaboration in education, research, and healthcare. To all participants, I encourage you to make the most opportunity. Please take part in the discussion, ask questions, and exchange ideas with our speakers. Technology will continue to change, but our commitment to lifelong learning and better patient care must remain at the heart of our profession. Dr. Lee and Dr. Chen, once again, thank you for joining with us. We hope today's lecture will bring you insight, meaningful discussion, and opportunity for future collaboration. Finally, I would like to thank our speaker, organizing committee, and everyone who has made today's event possible. With gratitude of Almighty God, and by saying Bismillahirrahmanirrahim, it is my pleasure to officially declare this guest lecture open. I wish you all the productive and inspiring session. Thank you. Good morning, everyone. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Sadevi, for the exceptional opening remarks. So before we start the lecture, we will have the photo session first. So I would like to invite all the participants and also Dr. Lee and Dr. Yang Chen to come forward and take picture. Silakan maju ke depan sebentar untuk dokumentasi.
Sure.
Now, without further delay, let me introduce our first speaker. Our first speaker, Dr. Lee Shir-Yang, is a senior consultant at the National University Cancer Institute, Singapore, and head of hematological division in the Department of Laboratory Medicine at National University Hospital. Her expertise include the diagnosis of complex blood disorders and integration of morphological, cytogenetic, and molecular findings. Today, she will explain one of clinical pathology most challenging domains, the myeloid malignancies with overlapping features, including myelodysplastic syndrome, myeloproliferative neoplasm, and MDS/MDN overlap entities. She will teach us on how different diagnostic approach can be integrated to guide clinical decision-making. Please join me in welcoming Dr. Lee Shir-Yang.
Yeah, thank you very much for the invitation to speak in this guest lecture again. So I'm very honored to be here to talk about the topic that I am very keen on explaining about, because it's to me it's a very interesting and very complicated subject, and things are still evolving very, very quickly, particularly on the diagnosis and molecular markers. So I'll be talking about myelodysplastic syndrome, myeloproliferative diseases, and the overlap syndromes, as well as acute myeloid leukemia. So particularly focusing on the myeloid disorders. So this is the agenda that I will be doing today. I will talk about the evolution of the diagnostic classification of myeloid disorders, and I will talk about chronic myeloid leukemia as the model for our understanding of myeloid diseases. And subsequently, we will go through one by one the different major categories like the myeloproliferative neoplasms, myelodysplastic syndrome, MDS, MPN, and acute myeloid leukemia. So why is the classification of myeloid neoplasm so important? I think the field actually advanced because everybody was referring to the disease by the same name. If we have got different names and different understanding of different diseases, then internationally, there will be differences in the progress of discovery of this illness. So in the seminal work that brought together everybody to agree on how we name different myeloid diseases happened in the 1970s. It started off with the FAB classification of that was primarily morphology driven. So in terms of morphology, AML was classified into M0 to M7, and we required a blast count of 30%. But in 2001, WHO came up with a revised unified classification into a single classification system, and throughout the world, everybody started using the World Health Organization classification. The most important change that they did was to reduce the blast count to 20% or more to qualify as acute myeloid leukemia. And one of the very important things that they brought together was the fact that to diagnose myeloid malignancies, we actually need the integration of morphology, immunophenotyping, and genetics. So this integration is most important in myeloid disorders, and in terms of the lymphoma diagnosis, this integration is a little bit come later than the integration that we experience for myeloid disease. Then fast forward to 2008, there was a revised 4th edition of the WHO, and nowadays we are at the 2022. All right, WHO, we call it WHO 5th edition or WHO 5. So, however, along the way, there are certain other communities that come up with other classifications, such as the most important one was the International Consensus Classification, or ICC for short. This came about in 2022, and the reason why this came about was that there was a group of pathologists and treating hematologists who felt that the WHO 5 didn't address certain things that they felt were important. However, from this year onwards, I think both groups of the WHO and the ICC will eventually come together again to harmonize their different classifications. So what I'm trying to say here is that there was a little bit of a divergence recently, but by and large, we still go with the WHO 5 as the most important classification for us. So what information do clinicians need from diagnostic workup? So firstly, we want the diagnosis, when morphology is the backbone. We cannot do a diagnosis without knowing the morphology and the immunophenotyping, etc. We cannot interpret the genes in isolation. We also want to give prognostic information. And the idea of the classification is that a disease category is driven by the mutations and it behaves in a certain manner. And that is why they come about this. However, for the clinician, it's not only using the diagnosis as for prognosis. Other information is also important for prognosis, such as In MDS will be the degree of the cytopenias. In lymphoma, what is the lactate dehydrogenase level? What is the ECOG performance score for the patient? How well the patient is performing? All this actually is and the stage of the disease actually goes into the prognosis. So what I'm saying here is that prognosis is not only based on genetics or diagnosis, but other clinical information of the patient may be important in the prognostic scoring system. And finally, precision medicine, what I mentioned before, targetable protein expressions, targetable mutations, and small molecule inhibitors. So I will use chronic myeloid leukemia to illustrate all these principles because it is a very nice disease to illustrate the whole principle from end to end. So we all know that chronic myeloid leukemia is a disease of the hematopoietic stem cell, and it is done by the driver mutation, which is the Philadelphia chromosome, and it's a translocation between the chromosome 9 and chromosome 22. So this translocation brings together the BCR as well as the ABL, which forms a constitutively active tyrosine kinase enzyme. So this tyrosine kinase is no longer suppressed, is no longer under the normal control of the cell, but it is active all the time, leading to uncontrolled proliferation. And the classic bone marrow you will see is that there is neutrophil and myeloid biphasic peaks in the neutrophil and myeloid cells. And there is this very unique small hypolobated megakaryocyte, and there is a lot of myeloid hyperplasia. So, however, to confirm CML, it is no longer just morphology, but we actually need to look for the BCL-ABL mutation. So there are three methods to look for the BCL-ABL. There's by cytogenetics, there is by a FISH, where it is a fusion probe that you see the fusion signals, and finally by the PCR. Okay, so there are three methods. So is any one better than the other? The answer is they are complementary. So about 10% of chronic myeloid leukemias will not show any abnormality on the karyotype. This is what we call a cryptic translocation, meaning to say the chromosomes may not show the classic 922, but when we do the PCR or the FISH, it will be seen. All right. And also you need to understand the PCR, your performance of the PCR, because there are different breakpoints between the BCL and ABL. There are different breakpoints. So if the PCR probe identifies only two of the commonest breakpoints, certain minor breakpoints will be missed by PCR. So that is also something to bear in mind. So for chronic myeloid leukemia, a patient has a very consistent clinical course, in the sense that the disease follows a very predictable pattern. So it is a very homogeneous disease. So typically the patient, if most will present in the chronic phase, and without TKI treatment or tyrosine kinase inhibitor treatment like imatinib, after 5 to 6 years, the patient will progress to an accelerated phase. In the accelerated phase, there is an increase in the blast to about 10 to 19% in the blood or bone marrow. And if the patient is not treated, then they will progress to blast phase within a year. And once a patient is in blast phase, the outcome is very poor. Even with TKI or even in bone marrow transplant, patients still succumb to the disease. And by definition of blast phase is blast more than or equal to 20% in the bone marrow. So as you can see, in the chronic phase, patients may not have any symptoms, but they might have a large spleen. And as they go into the accelerated phase, the spleen becomes increasing and they start developing symptoms like weight loss, constitutional symptoms. And when they go into the blast crisis, more and more symptoms will onset and they get more cytopenias. So in the classic chronic phase, the patient's platelet count is normal with only a slight anemia. As they go into accelerated phase, the platelet count may start dropping or it may become very high, not responsive to treatment. So thrombocytosis may onset. And finally, in the blast crisis, typically they have high white cell and low platelet count and anemia. So how does WHO diagnose, say that, what is the diagnostic criteria for chronic myeloid leukemia? Very simply, the peripheral blood and bone marrow findings, and there is detection of the BCL-ABL. That is the defining feature. If the BCL-ABL is not detectable, we have to rethink what is the diagnosis. It could be a typical chronic myeloid leukemia, or it could be some other condition like proliferative phase of myelofibrosis. We have seen the proliferative phase of myelofibrosis with very high white cell count, like 100 or 150. All right. So very important to look for the BCL-ABL by different methods if possible. And blast phase, no difference in the diagnostic criteria, detection of more than 20% myeloid blast, or if the patient has a myeloid sarcoma, meaning to say that if the patient has a mass somewhere and somebody does a biopsy, there is a proliferation or extramedullary myeloid blast proliferation in the biopsy results. And interestingly, if the patient presents with a high lymphoblast count of more than 5%, even if the lymphoblast is less than 10%, this is a very bad sign for the patient because it is like very early blast phase. If we leave it alone, by 6 months to a year, the patient will progress into lymphoid blast crisis. Okay. What is interesting is that in the old classification, there was an accelerated phase, but in the new classification, they omitted the accelerated phase from this disease. But I think many practicing hematologists, they don't agree. And so the ICC classification retains the accelerated phase. So what is the diagnosis of the accelerated phase? I have listed it here. Basically, if the bone marrow or the peripheral blood blast is between 10 to 19%, or if the peripheral blood basophil count is 20% or more, or if there is presence of additional clonal cytogenetic abnormality in the Philadelphia chromosome positive cells. All right. So, why it is important to keep this accelerated phase diagnosis is because in a patient with accelerated phase, even if they start TK tyrosine kinase inhibitors like imatinib, the chance of them going into a deep molecular remission is lower, and they have a higher chance of progressing to blast crisis. So, CML is like the poster child of precision medicine. So nowadays, just taking one pill a day is going to cure many of the patients. And you can see that by the survival curve, before tyrosine kinase, patients will die after 10 years, right? More than half the patients won't be alive after 10 years. But in the tyrosine kinase era, just taking one pill a day continuously, they have a 80 to 90% survival after 10 years. So this is an amazing development for patients. So I think other diseases that the treatment is, they are trying to model treatment based on CML. So we are trying to find, is there anything special in these other diseases that if we just give very targeted treatment to target the mutation of the cell, are we able to bring about a very good cure rate for this patient? So a lot of times when we develop drugs and we diagnose diseases, part of the thinking is, are we able to identify something that is so unique to this disease that we can predict what will happen to the patient? Can we predict how the patient is going to respond to the drug? And that is how the WHO come with the classification to incorporate all the mutations into the subdivision, the subtypes of the disease. So I will just talk a little bit about BCR-ABL1 transcript subtypes. So the majority of chronic myeloid leukemia patients have the P210 transcript, which is, I think it encodes a protein of 210 amino acids. So that is a particular size of the transcript. And this is related to the specific breakpoints, exon 13 of BCL, and on the ABL is the exon 2. So when the breakpoint happens there, this is it's 98% of CML patients have this breakpoint. The less frequent breakpoints include the E1A2, which encodes the P190 protein, and the E19A2, which is a P230 protein. And why is this important? Because very interestingly, a patient with the P230 protein, they tend to have high thrombocytosis, and they can mimic essential thrombocythemia. So sometimes in our patients, if we find that the white cells is a bit high, but the platelet is very high, and they have a very hypercellular marrow, we will actively look for the P230 transcript because they are a chronic myeloid leukemia. They will be treated with TKI. And if the CML patient has the P190 transcript, that actually carries a little bit more worse prognosis. The patients tend to have more monocytosis, absence of basophilia, and the tendency to progress to the lymphoid blast crisis. So the transcript type tends to be stable over time, meaning to say that if the patient had P210 at the start, upon monitoring, the transcript type is usually the same. They do not change to another transcript type. So what causes confusion is that at diagnosis, because of a P210 patient might have a bit of alternative splicing at the RNA level that gives rise to the P190 mRNA. So if the PCR is by the mRNA method, there can be very low levels of P190 mRNA transcript, but this is usually at a very low level. This is usually of no clinical significance because at the DNA level, it is the P210 transcript. All right. So this causes a little bit of confusion to some of our clinicians, and they will ask, is P190 detected? Is this important? Is this a BALL? Then we'll tell them, no, the majority is a P210. It's just a classic chronic myeloid leukemia. Okay, so next, the slide here I'm trying to show is that the mutations must not be interpreted in isolation. So for example, we have a 30-year-old man with leukocytosis, 80% blast, and no splenomegaly. And this cytogenetic shows a translocation 922 Philadelphia chromosome. So what is this diagnosis? If you look at the microscope, majority of the cells are blast-like, lymphoblast-like, and we do a flow. The red color population shows that it is CD19 positive, CD34 positive, and CD10 positive. So this is a classic BALL. So this is, and the BCL-able transcript is P190 transcript, no history of CML. So this is a de novo Philadelphia positive BALL. And the Philadelphia positive BALLs, the vast majority of cases have the P190 transcript, all right, which is the E1A2 transcript. So how do we differentiate a patient who comes in with CML in lymphoid blast crisis versus a Philadelphia chromosome positive de novo BALL? Because the outcome of the patients is quite different. CML in lymphoid blast crisis, in our center, we will give chemotherapy with TKI followed by a bone marrow transplantation because the outcome is actually very poor, which is much poorer than the de novo BALL. So some of the pointers here is that we have to look at the other leukocytes, of course. So in a patient with CML lymphoid blast crisis, they tend to have a higher leukocyte count, higher neutrophil count, more immature myeloid cells in the peripheral blood, lower percentage of the B lymphoblasts. However, in a patient with and in the laboratory features, there's usually a large discrepancy between the blast count and the Philadelphia positive clone. The Philadelphia positive clone will persist when the BALL is in remission, and the BCL-able fusion is detected also in the neutrophils. If we do the flow cytometry sorting and then we sequence the neutrophils will also carry the BCL-ABL fusion transcripts. And okay, I'll move on to myeloproliferative neoplasms. So I think for this, the classic ones are polycythemia vera, essential thrombocythemia, and primary myelofibrosis are by and large the most commonly encountered MPNs. I won't go into so much detail, the chronic neutrophilic leukemia, chronic eosinophilic leukemia, because I think that one is quite rare and there are certain diagnostic criteria that you can refer to. So for PV, the typical picture is that they will come with elevated hemoglobin and hematocrit. They tend to have splenomegaly, and this is a diagnostic criteria. Fortunately, for the WHO5 and ICC, the same criteria is given. So what is interesting is that usually we will require all three major criteria or the presence of the JAK2 with polycythemia plus a minor criteria. So what are we trying to say? So in situations where JAK2 mutation is not so easily available, we can actually do a bone marrow a biopsy, and then it will be very hypercellular. However, if a patient presents with very high hemoglobin, more than the 99th percentile, so more than 18.5% in men or 16.5% in women, and we do the JAK2 mutation from the blood, and we do the erythropoietin level, which is very low, suppressed, we can be quite confident that this patient has PV even without needing a bone marrow biopsy. So a bone marrow biopsy may not be required in such patients with very high hematocrit, presence of JAK2 mutation in the blood, and very suppressed and low erythropoietin level. So how about ET? So what the thing to note here is that the platelet count for ET is no longer more than 600. The platelet count criteria is persistent thrombocytosis of more than 450. And to diagnose ET, we either need all the major criteria, meaning to say high platelet count, a bone marrow biopsy, or an exclusion of other more common other important disorders like CML, PV, and primary myelofibrosis. And and as well as a demonstration of JAK2 calreticulin or the MPL, which is the megakaryopoietin receptor mutations. So I think the challenge for ET is that in the absence of clonal mutations, number 4, JAK2, CARL, or MPL. In the absence of this, are we able to make a diagnosis of ET? The answer is yes, but you will need a bone marrow biopsy to show the typical megakaryocytes that with hyperlobated nuclei. Okay? So, and the challenge for high platelet count is that reactive secondary causes of thrombocytosis is quite common. Usually we have to ask a clinician to make sure that it's not reactive, meaning to say it's not due to infection, it's not due to iron deficiency, etc., etc. If we are not able to demonstrate the mutation, we have to make sure that it's not secondary causes. If secondary causes are excluded, we do a bone marrow. If the bone marrow shows megakaryocytic hyperplasia, then we can actually make a diagnosis of ET even in the absence of the mutations. So in the era of NGS, of course, if the center is able to perform NGS, sometimes we will be able to identify other mutations that are the non-JAK2, non-CARL, non-MPL mutations that might happen in this so that we can make a diagnosis of ET. So how about primary myelofibrosis? So I think myelofibrosis is quite straightforward. Typically, the patient will present with very large spleen. They will have anemia, and the platelet may be low or may be normal. So I think what is important to recognize in this day and age is that there is this two categories of ET. One is the pre-fibrotic ET, the other is fibrotic ET. Pre-fibrotic MF, the other is fibrotic MF. So fibrotic myelofibrosis is a classic one where we do the bone marrow, there's a reticulin is 2 or 3 is increased. And then the patient has a leukoerythroblastic picture, has an elevated LDH. Whereas pre-fibrotic MF may present as a very high white cell count or a very high platelet count. And with very little reticulin inside the bone marrow. But patients with, if you catch the patient early, of course, might be pre-fibrotic, but over time, they will progress to become fibrotic MF. So that's what we mean by this timeline, where pre-fibrotic MF over the period of a few years may progress to fibrotic MF. So what does this mean for the patient? I think essentially the take-home message is that pre-fibrotic MF exists. It is when the reticulin in the bone marrow is less than 2. So 0 to 1 out of 3 grade of reticulin. And how we need to be careful about is that we need to distinguish reactive fibrosis from myelofibrosis. Because in some situations, we can get reactive myelofibrosis. So the situations that I have encountered are things like autoimmune conditions, like SLE. Sometimes they can cause myelofibrosis. Of course, if you have got other things like hairy cell leukemia in the marrow, it can cause increased fibrosis of the marrow. So again, we have to look at the patient's clinical picture. We have to look at the minor criteria, meaning to say anemia, leukocytosis, LDH level. Does the patient have a spleen? And then we look for clonal mutations like JAK2, CARL, and MPL. If we have clonal mutations that belong to one of these, then your diagnosis is made. It's quite simple, straightforward. This is myelofibrosis. If we do not have any of the 3 mutations and we have NGS, we can look for myeloid-associated mutations like ASXL, EZH2, TAT2, IDH1 and 2, etc. If we have those mutations, then our diagnosis of MF also more likely. So it is only if we do not have any of these mutations, then we have to make sure that that it is not a reactive, that this is a primary myelofibrosis picture. So going forward, there's also the distinction between ET and pre-fibrotic myelofibrosis. And why is this important? Actually, to the patient, to be honest, to the patient, the treatment is not different. So if a patient has pre-fibrotic myelofibrosis or ET, initially they are quite well. Usually they are quite well. They don't have many symptoms. They may not need any special difference in the management. However, the survival is actually quite different between the two. So if a patient has ET, the median survival is 30 years. You can say that, yeah, don't worry, you'll be fine, you must just make sure the platelet count is not too high. The patient is at risk of stroke, so you just give a bit of aspirin. However, in the pre-fibrotic MF, the survival is lower. And in centers where, if a young patient in centers where they might have bone marrow transplant capabilities, we will watch for early progression and we will offer more aggressive treatment if the patient progresses to MS. Okay, so there are some differences here. I won't go into too much detail. So this is the distribution of the frequency of mutations in the 3 major illness. So for PRV, 98% of the time, they have got a JAK2 mutation. Most of it is in the exon 2, exon 14, V617F, 88%, whereas some of them are in exon 12, about 5%. It's only less than 5% of the time they have no mutation in any of the 3. However, in ET and MF, you can see that JAK2 is in about half, CALR mutations about 20%, and MPL mutations in about 10%. There is that about 10 to 15% of cases that they do not have any mutation in any of these 3 genes. Okay, so there are JAK2 inhibitor drugs available for MF. So we will come to MDS and what is CHIPS and CCUS. So for MDS component for diagnosis, as you all be familiar, is that this is a hierarchy. It's like a pyramid. You need to have the foundation. Then you talk about genetics. So the most essential presence criteria is that the patient must have cytopenia. If you don't have cytopenia, it's not MDS. So you need to have cytopenia. Then you look at the bone marrow. You need to have dysplasia. All right. Then after you establish that dysplasia, you look at the blast percentage. All right. And you need to count the blast on both the blood and the bone marrow, because both blood and bone marrow blast count is important in classification of MDS. Then after you have the blast count, you look at whether there are ring sideroblasts in the prostate. And finally, you analyze the mutation with the NGS and with the cytogenetics. So because NGS is becoming quite common in the Western countries, some people, do research studies and in patients, and they come up with two different situations. So one is called CHIPS, which is clonal hematopoiesis. The other is called CCUS, which is clonal cytopenia of undetermined significance. I would say that even in Singapore, sometimes we don't even bother trying to diagnose this. So what is CHIPS? CHIPS is where the patient has no cytopenia, so perfectly normal full blood count, and there is no dysplasia. But when we do the mutation on the NGS, we find myeloid mutations. But the VAF cutoff needs to be more than or equals to 2%. So if it is less than 2%, you kind of just ignore it. So if that's the case, we call it CHIPS. So basically, patient is well, we don't do anything about it. Just monitor, say, hey, you're fine, I'll see you once a year. Okay? However, if the patient has cytopenia, which is CCUS, patient is anemic, thrombocytopenic. But when we look under the microscope, the dysplasia is not really present. I don't see any dysplasia. But I send the NGS and there is myeloid mutation with a VAF more than or equals to 2%, then I will call it clonal cytopenia of undetermined significance. Again, we don't do anything different. We just monitor the patient, but we will tell them that, hey, you have a 20 to 50% chance of progressing to MDS in about 1 year or 2 years. Okay, so that's prognostic. So this is just a summary. So for CCUS, there is cytopenia, but everything else negative, but there is genetic mutation. For CHIPS, so there's no cytopenia, no dysplasia, no increased blast, no rings, but the genetics is abnormal. Okay, so this is just a summary of these two categories. So I think for WHO5 MDS, they have simplified it very nicely, which I appreciate, because in the WHO4, it's so complicated. There is single unit dysplasia, double unit dysplasia, but the WHO4 classification has really no impact on how we treat patients. So this is actually more simple for the diagnostic clinical pathologists to understand. So we only have MDS with low blast, which is blast less than 5%. I think all of you are familiar. But what is interesting is that they have hypoplastic MDS, and this is hypocellular marrow. Why do they bring this up as a category? It's because this category we treat with immunosuppressant. And actually, they do very well. They have they can live very long, and they respond very well to immunosuppressants. So, of course, you are also familiar with increased blast 1 and 2, which is the standard definition there. The bone marrow blast between 5 and less than 10%, and increased blast 2. Sorry, there's a typographical error. The last row is IB2. Bone marrow blast more than or equals to 10% to 19%. Okay. So WHO also identifies 3 categories that are genetically defined. So the deletion 5q, those with ring sideroblasts, and finally biallelic TP53. So why are these important? And this is because the first 2 categories, they have good prognosis, and there are specific treatment available. So for example, deletion 5q, we treat with the lenalidomide. Whereas for ring sideroblasts, usually we just treat the anemia, all right? And they can have very good outcome. However, the biallelic TP53 is a very poor prognosis player. We can give chemotherapy, we can do bone marrow transplant, but frequently they will relapse. And sometimes we will say that, palliative care. So what does biallelic TP53 inactivation mean? This means that we all have TP53 is a tumor suppressor gene. So we have two alleles of TP53. If we find that there is a mutation in one, and we find that there is a deletion in TP53, for example, on the cytogenetics, we see there's a chromosome 17p deletion, or in fish, there is 17p deletion. We know that both the alleles are mutated. So that will be biallelic. All right. So this is just to show you that based on your cytogenetics, your blast count, as well as the patient's hemoglobin, platelet, and neutrophil count, we can come up with a scoring system and we can predict how well or how badly the patient is going to do. And you can see that at the top line in the bold, that is if the patient has lower risk score from the prognostic score. And as the prognostic score increase, the outcome becomes poorer and poorer. So how about mutations in MDS? So there are certain mutations that are more common in low-risk MDS, which is at the lower left. So things like DMT3A and SF3B1. SF3B1 is associated with MDS with ring sideroblasts. Those are at the lower risk MDS. However, at the higher risk MDS, you can see things like TP53 mutation, CBL, SEPA, KRAS, AXXL1, and RUNX1. And those usually confer a higher risk of progression to acute myeloid leukemia of the MDS. So what about MDS MPN? I think you are aware that this is an overlap between MDS and MPN. So they have got dysplasia, but also they have got proliferative features like high white cell count or high monocyte count. So essentially, there are 4 categories. So the most common is chronic myelomonocytic leukemia, followed by MDS with ring sideroblast and thrombocytosis, and atypical chronic myeloid leukemia. So atypical chronic myeloid leukemia usually might be mistaken morphologically as chronic myeloid leukemia, but they have a lot of neutrophil dysplasia. All right. So let's talk about CMML. So what is important to remember now is that the monocyte threshold for diagnosis CMML is now lower than before. It used to be 1 or more, 1 times 10 to the 9 per liter or more, but now the WHO has reduced to 0.5 times 10 to the 9 or more. And of course, there is this abnormal partitioning of the peripheral blood monocyte subsets, which I think on the floor, many of y'all will be able to identify. Okay? Based on CD14 and CD16 immunostaining. So what is common in CMML? So I would say that almost all patients with CMML, if you run the NGS, they will have some form of mutation in the myeloid gene, such as SRSF2, TET2, ASXL1, SEPTP, and KRAS, RUNX1, CBL, and EZH2. Some of them may have low-level JAK2 and SETBP1 and RAS pathway mutations, which tend to be associated with a higher white cell count. Low-level JAK2. Okay, so I will talk about chronic myeloid leukemia as a very last disease. So we mentioned yesterday that chronic myeloid leukemia is a heterogeneous disease. So we have put in different types of mutations that tell us what that subtype. So why is this important? So I think by and large, treatment will be pretty much the same, but prognosis might be different. All right. So many of them are associated with good prognosis. So for example, the inversion 16, 821, NPM1, and the SEPA mutations, they generally respond better to treatment. So for AML with defining genetic abnormalities, the blast count threshold has been removed from this category so long as you can demonstrate the mutation. So this was a bit controversial because ICC group didn't really agree, but we will see what happens in the next iteration of the WHO. I'm not sure whether they will bring back a blast count threshold. So except that, for the others like BCL-ABL, CBPA, we still need 20% or more blast to diagnose AML. So this is just a kind of flow chart to help us to subtype under the WHO 5. Okay. So basically, we look at the blast count as a priority. If blast is more than or equal to 20%, that is, if they have defining cytogenetic abnormalities, no blast count cutoff is required except for BCL-ABL and ABL fusion or SEPA mutation. If the blast count is more than or equal to 20%, that is acute myeloid leukemia. And if it's less than 20%, AML is not diagnosed. So under more than 20% blast, the question is, are there MDS defining genetics or prior MDS or MPN diagnosed? If yes, then it is an AML myelodysplasia related. If no, then we go to AML defined by differentiation, and we go by with all the morphologically defined AML subtypes. Okay, so what is CEBPA mutation? I mentioned before. So to cut the long story short, what is important to go into this category, because it is good risk, is only if the patient has a very specific type of mutation in the C-terminus B zip region, because this is an in-frame mutation, meaning to say that there is an in-frame, so there is no shift of the reading frame, and so there is a specific mutation that doesn't really affect the protein structure that much. And so this is the most important mutation subtype that you need to look out for when you do the NGS. All right. So it can be double mutation or it can be single allelic mutation. It doesn't matter as long as this patient has the in-frame BZIP region mutation. And this is generally a good prognosis. And I won't go into too much detail. We used to have AML with MDS, but to cut the long story short, what they are saying is that you can only diagnose this category if the patient has a history of MDS or they have certain molecular and cytogenetic abnormalities present in this list. In the past, if the patient, they allowed you to diagnose this if there's morphological dysplasia. But morphological dysplasia is no longer a part of the diagnosis of this entity. So you can diagnose this only if the patient has background MDS or has specific cytogenetic or molecular abnormalities. Because in general, these patients, they don't respond so well to treatment and the prognosis is different. So I will just talk about acute pure erythroid leukemia. So pure erythroid leukemia morphologically can be a little bit challenging because they are abnormal pro-normoblasts or pro-erythroblasts. What is very characteristic is that they have vacuoles in the cytoplasm. We call it, they look like pearl necklace appearance. And basically, I show you a pearl necklace because the vacuoles, they line up in a very nice line like that. So we have also made a mistake. Are they lymphoma? Are they plasma, abnormal plasma blasts, etc.? But based on the flow cytometry, you can tell very clearly that this is erythroid precursors. And the phenotype of erythroid precursors is that they are CD45 negative. So if you look at the purple color population with the orange arrow, it is 45 negative. They are CD105 positive, CD71 positive, and CD36 positive. And because they are pro-erythroblasts, they are fairly immature. They can have CD117, and they might have even CD33, and HLA-DR is usually negative. So this is very characteristic erythroid markers, 105, glycophorin A, 36, and 71, and you can make a good diagnosis of that. And finally, what does this mean? You go to so much trouble to kind of subclassify it. Does it mean anything to the patient? The yes and no. The initial treatment is the same. We give chemotherapy to all patients. But in certain patients, like those with very high-risk mutations like TP53, we will try to put them to allogenic stem cell transplant in order to cure them. Otherwise, the relapse rate is very high. And of course, if there are FLT3 inhibitors, we will use them. IDH1 and 2 inhibitors, CPX351 for AML with myelodysplasia-related changes, and CD33 gemtuzumab, anti-CD33 gemtuzumab. So in summary, myeloid disorders is a very broad range. We try to subtype it because we know that integration of the genetics will predict the behavior of the patient, as well as we will also be able to see if there are targetable molecules or targetable drugs that can actually help the patient. And for us, we should be aware of these changes and be prepared to handle the increasing test demand from the clinicians. So with that, I thank you very much.
For a very insightful presentation on diagnosis integration in the complex modern hematopathology. We now move from broader diagnostic perspective to more focused look at molecular testing, specifically the role of next-generation sequencing in the genetic evaluation of patients with hematological malignancies. Our second speaker, Dr. Yang Chen, is Business Development and Senior Application Specialist at Nanotech and Biotechnology China. Dr. Chen is an expert in next-generation sequencing with experience in its clinical application, particularly in hematological malignancies. Her expertise includes NGS assay development, validation, implementation, and genomic data interpretation. Today, she will discuss the significance of NGS in the genetic evaluation of patients with hematological malignancies, including its role in disease classification, risk stratification, and targeted therapy selection. She will also share practical consideration for implementing NGS testing, illustrated through real-world case. Please join.
Okay, hello everyone. So I'm Yang Chen from Nanotech and Bio. I'm based in China. So actually, it's really a great honor to be here to give this presentation again about the significance of NGS for hematological malignancies. So actually, before we talk more about the hematological malignancies, we would like to introduce some information about NGS first. So from the slide, we can see that the genetic information starts from the DNA, and after transcription, it will have the transcript to the RNA. After that, it will translate to the protein. It's like the information will begin from the genotype to the phenotype. So naturally, for a lot of kinds of disease, like the cancer or other kind of the inherited disease, it began with some genetic variation, like a somatic mutation or the germline mutation. And after that, there is a lot kind of the variation that just happened, and it will lead to such kind of the serial situation. So actually, on the right, we can see that on the genome, there is a lot of kind of variation type, like so you can see here about the references, the genome information, and it will have some the sequencing variation like the SNP, like the insert or the deletion, and also it will also have some kind of structure variation. It will be a more large region like the CNV change, deletion, and the amplification, and also we will have some like the translocation, such kind of the variation. And actually, for now, if we for a lot of kind of the disease and the tumor, it will from the phenotype detection method to the genotype driven method, and also we can also combine these two kind of methods together to get more reliable and precise detection result, and to get more precise therapy direction. And we know that for the human, the genome, the full length of the human genome references genome will be the 3 gigabase, which means that a lot kind of information. And if we want to focus on the one kind of the cancer type, there may be a lot of kind of the related genes and related to the variation information. So we would like to involve a new technology to get to perform the high throughput sequencing to get a lot of the information in one run. So this is which we would like to introduce about the next generation sequencing, the NGS. So here in this slide, we show the mainstream sequencing principles from the MGI and Illumina, and we can see here by so after we do some treatment with the initial sample, we get a nucleic acid and we add the ID. Then we can perform the sequencing on the mainstream sequencing platforms, and we can get millions of the sequencing information in one time. So actually, before we perform the sequencing on different platforms, because we see that the initial information will be some like the blood or tissue, so we need to do the nucleic acid extraction to get the DNA and the RNA template. And after that, because we see that for the sequencing, maybe we need to mix different kind of sample together to for sequencing. So we need to involve some kind of the ID or the barcode to differ from different samples. So which means that after we do the extraction, we need to perform the library preparation. In this step, we will add a different barcode and ID for one sample. After that, with this kind of sample, every molecule in this sample, it will have the same barcode. So after that, we can, if we put that to the to perform the sequencing, we can just split the data and to go to the further analyze. So in this slide, we can see that actually, if we just finish the library preparation and we perform the sequencing, it will like the huge genome sequence, the WGS, the huge genome sequencing, and we can get all kind of the variation information. But because we see that the human genome will be very large, so there is a lot of information. Maybe it's not related to this kind of the disease, and we will waste a lot of the data volume, and it will be very complex with such kind of data analysis. So sometimes for now, they already have a lot of kind of the research and a lot of kind of the guideline publication, etc. And it will has clear about maybe one kind of the variation, one kind of gene biomarker will place a very criteria in which kind of the cancer type. So in this case, if we can just selected the information sequencing we want, we do the enrichment, and then we can perform the sequencing just to perform the higher sequencing and to get more reliable result. And also we don't need to waste so many time to analyze so complex information from the sequencing data. So how we can achieve this kind of the point? Actually, for now, we rely on the equiphase based enrichment method. It like that we can so the green region is the target region. It means that this region we want to check with the sequencing information to check whether there is a variation or not. And then we can design the prep based on this sequence, and we can design the complementary sequence to target this region. And this probe, it will have the biotin modification in target to combine with this probe. And after that, we can use the streptavian beads to enrich the total complex. And after that, we can do some wash step to remove some the unspecific region, and we want to all the sequencing data will focus on the region we want. So by this way, we can perform, as I said, the deep sequence and get more reliable and precise information about the variation. And such kind of variation information can be used for the further like the combining diagnostics and also the diagnostics, and also some kind of the molecule mechanism. It can be used for the therapy treatment information to give us such kind of therapy guide. So for now, this kind of the hybridization, the enrichment method has been used in a lot of kind of application scenarios, like we have known about the NIPT, and also the combining diagnostics for the newborn screening, for the inherited disease, and also for the solid tumor. A lot of kind of the product and a lot of computer company has been focused on this kind of application and developed a lot of kind of the product. And today we also want to use this kind of technology in the hematological malignancies. We want to involve the different kind of the biomarker related to different kind of blood cancer, and to go to the further combining diagnostics and also the pre-diagnosis and also the therapy guide, etc. And also maybe the MRD detection. So then how we can use the NGS for the hematological malignancies, the detection, the combining diagnostics, and the further applications. So actually, we already know that. I think you have been very experienced with the hematological tumors. There are a lot kind of the blood cancer type, and the different of cancer type also originate from the genetic disorders, the somatic mutation, and the different also the maybe and I think the blood cancer also have the heterogeneity, so it will make it very difficult to detect with the mechanism and give a more precise therapy direction. And now I think a lot kind of the method has been used in the hematological malignancies detection, like the based on the FISH and etc. method. And this kind of method also they need to based on the fresh sample type, and they will have also have different those application scenarios. And what NGS can do is that we don't need the fresh sample. We just need to get the nucleic acid, like the DNA or RNA template. After that, we can perform the experiment to perform the deeper sequence to analyze the variation information. And for now, the NGS can use to detect with the detailed information for the routine genetic testing for the variation, and also can use for the MRD detection and etc. such kind of application. And I think for now the strategy for the hematological malignancies, maybe you will combine different kind of methods together, like combine with the flow different kind of methods together to get more reliable result. And we see that for different kind of the hematological malignancies, they will have the different kind of the biomarker, the gene, drive genes, and also different kind of variation type. So for now, actually, a lot of kind of the database and experts consensus, also some kind of publications has do a lot kind of research and have to select the most important biomarkers related to which kind of the blood cancer type. And then if we can just involve this kind of biomarker, it can be a very powerful tool in the hematological malignancy detection scenarios. And beside all the genes like the fusion, just the Dr. has introduced, and also we want to involve the other two kind of the biomarker. One is the IGTR, the B cell and T cell receptor. Actually, for the hematological malignancies, we say the B cell and T cell blood cancer type, it will have to involve the T cell B cell recombination. And during this process, if anything wrong, like the gene mutation or the recombination have some abnormal rearrangement, it will result in like some kind of the monoclonals will have the abnormal polymorphisation, and it will result in such kind of the blood cancer type. So we can involve this kind of the biomarker inside the very important biomarker we can use to check whether it will be a B cell or T cell blood cancer type, and also for different kind of the different individuals, the IGTR will be different. So this biomarker can be also used for the MRD detection, etc. So actually, sometimes we will for the IGTR detection, we involve the most important CDR3 region, because there are very high diversity and it will place a critical roles in its IGTR function. And so we can design the prep to cover the IG and B cell, T cell coding, the genes coding region to gather variation and to gather rearrangement information. And beside for the coding region, for the B cell, it has a special region we call the IGH switch region. Actually, it's located in the intron region. And after the B cell has a recombination, it also need to do the antigen switch to meet the diversity requirement for the anti-immune requirement. So it will have the double strand break in the switch, the IGS switch region. At the break, it meets the double strand repel here, and sometimes it will have something wrong with the repel, and maybe the IGH switch region will have some fusion, like have some recombination with some the cancer drive genes like the MYC and etc. And by this way, the most important the function module like the enhancer and the promoter will also increase and will affect with the cancer drive genes expression level, maybe will increase the MYC expression level, and this kind of the abnormal will also lead to maybe there's kind of the cancer just happened. So I think maybe for now for most kind for the B cell related to the blood cancer type, we can involve the IGH switch region to get more comprehensive analyzed result. So actually, based on the different kind of biomarkers, the genes, cancer drive genes, and just as I introduced the IGH, the IGH switch region and the IGTR, we developed two kind of the commercial products can be used for the blood cancer diagnostics and also MRD detection. First, for the combining products, combining diagnostics products, the NanoHema panel version 2. It's a big panel, comprehensive panel. We divided into two parts. One part is the DNA tube. In this tube, we based on the DNA template to design the program. So we cover the more than 400 genes, the full CDS region. So by this kind of design, we can check with the biomarker, the different kind of variation like the CMV, indel, SMP, etc., such kind of variation information. and maybe some kind of the variation has been some like the FDA or NMPA and other kind of database has do some kind of interpretation, and this kind of variation maybe has a pathogenic, clinical pathogenic function. And beside of the 4 CDS region, we also involved the 12 selected intro region, because we think that this kind of the intro region can be very important for some kind of fusion detection, because actually the fusion often happens in the intro region. But if we want to detect with a breakpoint, it will be better if that we use a DNA template to check with the fusion breakpoint and also some kind of information for fusion. Beside for these two part of the biomarker, we also involved, just as I said, the IGH switch region and some long coding region. Maybe you will have some the CLINVA related to the CLINVA database. So this is for the DNA template. And just as I said, the fusion will be very important biomarkers in the blood cancer detection. And the fusion often happens in the intro region. And if we need to based on the DNA template, the intro region will be very large, and it will be very hard to cover the full intro region. The cost will be very high. And also the intro region have some the repeated region. So if we just we want to cover this region, it maybe have some risk of off target. So it will be very hard to have the very complex coverage with the total intro region. And beside, sometimes if some maybe some fusion just happen in the DNA template, but after the transcription, maybe it won't have the function. It won't be being experienced in the following translate step. So we want to solve this kind of problem. So we involved the RNA tube. So this tube is based on the RNA template. So it can solve the problem we just said for the DNA template if we want to check with the fusion information. So in the RNA tube, we involved the 146 genes, the UTR and the CDS region to want to have the comprehensive detection result for the fusion detection. And we also, because we just introduced the IGTR, will be important. So we also involve the VDJ recombination probe inside this RNA tube. So with this design, I think it can meet a very comprehensive detection requirement for the blood cancer. So in this panel, when we designed this panel, we involved the most common blood cancer type, and we involved the related biomarkers. But actually, this panel is 2.4 megabase. So maybe if you think it will be a little large, we have the split tubes, which means we have the separate tube. If you just focus on the specific type of cancer, we can provide you with a separate tube, like the ALL, etc. So this is the design, the basic information about this panel. And after that, we also want to highlight the application scenarios of this panel. We can use it for the combining diagnostics because, as I said, a lot of kind of the FDA and the NMPA has been proved that such kind of the detection method can be used for such kind of the different kind of the blood cancer detection, combining diagnostics. And also, as I said, that we have involved in some kind of biomarker, and it can be sensitive, maybe some for the MRD detection, like the IGTR, and some kind of the genes variation can also use the prognosis diagnostics. And also, if we can check with the because the blood cancer has a heterogeneity. So if we can have the detailed information about the molecular mechanism, can also use for the therapy. Can be also used the therapy guide direction. So here actually we give you the information about the gene list we involved in this panel. These two slides will show the CDS region for the DA2 and also the selected intro region for the DA2. And for the RNA tube, we also involved a lot of kind of the important fusion genes in the RNA tube. And besides for the basic information, we also want to show you some performance with this panel. We use the sample already have the different kind of the variation information, and it will have the references allele frequency, mutation allele frequency, and we perform the sequencing on MGA and the Illumina platform, and we can check with the allele frequency will be very consistent with the references one. And we also involved the negative control, and you can see here in the negative control we don't have detected with any false positive result. This is the result for the DNA tube, and for the RNA tube we also use the cell line that contains some fusion information, and you can see here with the panel we also can check with the fusion happens in this kind of sample. So after wet lab, after we perform the experiment, we perform the sequencing on different platforms, and we need to deal with the sequencing data like the FAST field. And actually later I will introduce about our bioinformatics software to show you how we can make the sequencing data visualized and to show such kind of the demo report. Actually, in the report, we will involve because we selected the clinical sample information, and we will perform the further perform experiment. So in our automation, in our software, we will associate it with the patient information, the sample information, and the final analyze information together. And we will use different kind of the flood conditions to flood the background noise, and sometimes maybe the false positive result. And after that, we will give you the detailed information for different kind of variations like the indel, CMV, and we will based on the different kind of the references database like the ACMG, CLINVA, and the COSMOS and such kind of database to do the interpretation. To interpret maybe this kind of the variation will have the clinical pathogenic or the pathogenic, give you different level to help you to understand about the sequencing, the variation data. And these products actually we develop this panel for the combining diagnostics, and also we see that for the cancer, for the different cancer type, for the solid tumor or the blood cancer, after we do some treatment, we also need to do the MRD monitoring to check whether it will have the recurrency risk or not. So we give you another panel we call the Mucala AML panel. This panel is specially designed for the AML MRD detection. So here we list the basic information about the biomarkers we involved in this panel. We refer to the COSMIC and the TCG database to select the biomarker, and we do such kind of investment. And you can see here, like the nearly 90% of cases contains at least one mutation, and actually because it will be. We have when we used the biomarker in the clinical situation, we have a different reference standard and we have different requirement. So you can check with the biomarker first, and if you want to involve the more biomarker, it will be okay. So this kind of the products will be a little different from other kind of the products like I just introduced the HEMA panel and also the WEST panel on the market. Most of the prep, the NGS panel, they based on the traditional 120 NT prep. So actually, for such kind of the situation like the MRD detection, the panel size won't be so large. And if you just use the traditional prep, we see that it will have some problem. Maybe it will be very hard to get a very high on-target rate. The high on-target rate means that most of the sequencing data can be focused on can be used for the target region analysis. But if we cannot get high on-target rate, which means that most of the data just waste. There will be off-target data. It cannot be used for the further analysis, and it will waste so many data volume because for the MRD detection, sometimes the allele frequency will not be so large, so we will not be so high, will be very low allele frequency. So we need to perform the higher sequencing depths, maybe the more than 20,000 times, etc., which means that the data volume will be very high. In this kind of situation, we need to solve this kind of the low on-target problem. So we involved this Mucala, the hybridization system. When you check with the image here, you can see here the mechanism will be very different from these two kind of the hybridization system. So the traditional, it will be 120 NT prep, and the Mucala is shorter. It will be the 20 to 100 NT unequal length. So with the shorter length, it can combine with the fragments with a shorter time, which means that we can reduce the turnaround time. And besides, so with the shorter length, how we can ensure about the target specificity? You can see here, after the prep target fragment, it will also combine with the fragment with the prep near it. So by this kind of design, we can make sure the combination will be very fast and fixed. And third part is that you can check with in the same region because the prevalence is shorter. So with the same region, we will have the biotin modification. So with the capture, it will have the higher sensitivity when we perform the capture, and it also can reduce the capture time. So actually, for now, this kind of the system has been used in the early cancer screening and also the MRD detection, especially for the smaller panel size and the pathogen detection. So actually, the Mucala AML panel, we also based on this kind of the hybridization system to design the prep and to develop this panel. And here we want to show some performance with this kind of system and with this panel. So actually, you can see here for the same prep, if we use the traditional one, if we want to reach the same effective sequencing depths, we need more low data because the on-target rate is smaller than the Mucala system. So to be simplified with the Mucala system, we can reduce the raw data volume, which means that we can reduce the sequencing cost. And besides, how we can achieve that is that we can get higher on-target rate. You can see here for the very smaller panel, like the 40 kilobase, it will be very small panel. With the traditional one, the on-target rate will just like the 30 or 40% will consider to be very good performance. But with the Mucala technology, you can see here the on-target rate can exceed in the 80%. And besides, actually, with the traditional prep for such kind of detection, it will also very hard to repeat the result with different batches. And with this technology, you can see here, with different batches, the on-target rate will be very stable. And So after the capture performance, we want also to show you some of the detection result. We use samples already involve the different kind of variation, and with the references at the frequency, and we simulate with standard to simulate different kind of proportion, with different proportion to simulate with different kind of added frequency. And then we use this panel, we use different kind of method with the Mukella and with the traditional probe to perform the experiment to check with the variation information. So here you can see here, with the Mukella, we can have after we flood the background noise, we can get higher frequency depths, and we have the more rate to support this kind of variation information. So it will be more sensitive actually with the MRD detection, more sensitive and can reduce the frequency data volume to reduce a lot of the cost. So this is our software also have designed, have developed the pipeline for this kind of panel. We can analyze the result and output such kind of the report. So this is some information about the Mukella AML panel. And actually, because as I said, except for the panel design and the wet lab, the analyze will be very important. So we would like to have a brief introduction about our bioinformatic analyze platform. So actually, because we see that after we get the sequencing data, the FAST file, we need to analyze to check with different variation, and we also need to make such kind of variation can be visualized to make you more clear to check with the variation and to get the interpretation. So our software want to solve such kind of problem. We want to associate it with the patient information, the sample information, and the data information together. So we check with some kind of the patient. You can just get a further analyze result with the variation. And this kind of the automation software, we can support the automated report, which means that we have set the flood conditions, and you can use the system ready for use the condition, the parameter to flood different kind of the maybe unclear pathogenic variation or maybe such kind of variation will not related to this cancer type. Or you can flood by yourself. You can select the variation you want to output on the report. And so this is the interface about our software. We will show you, because there was some like the computer information. We will show you how many samples have been analyzed, how many report you can output now, and how many memory has been left for the further use. And maybe when you check there is no high memory left, you may need to remove some the data inside already has been analyzed to left more space for the further analyze. And then actually you can see here we have the on this part we have the show different kind of you can management with the patient information, the sample information, the data information, and you can select different pipeline to create a new project, and you can upload the data and for the further analyze, and you can on the test management you can download the report. And because actually the NGS the wet lab will be very important, and we upload the FASTQ file. So we need to check with the QC part to check whether the wet lab is okay or not. So we need to check with the on target rate will be enough or not, and also we need to for the set kind of semantic variation. We need there be if the enough effective sequencing depth to support the reliable analysis of the variation. So for the HEMA panel, maybe we recommend like the 1,000 times of the sequence depth for the analyzed. And we also need to check with the uniformity, like the 0.2 times mean. This is also a very important parameter to analyze the coverage uniform. Because if the uniform is very poor, which means some region maybe have enough sequence depth and some region won't have the coverage sequence depth, and the analyzed result will be affected with such kind of information. So the QC part will be very important. And after that, we can, this is for the somatic variation information, the mutation analyze. So actually, if you just use the system, the parameter already for use the parameter, you can just check here first you can check with the IGV to say this kind of the variation will be true or not. And also you can download the report here. This is if you want to use the system already used parameter. And also we support the customized report, which means that you can also set some flirt condition to just flirt the variation you want with the variation, the VF with a specific VF and etc. different conditions to customize your panel, the report. And this is for the fusion detection. Also, actually for the fusion, it will be very special compared to other kind of variation, because we need to actually when you check with the report and you see there is a fusion, you can click to the IGV to see whether there is a soft clip raised or not. So it will be some way to help you to check whether this kind of the variation will be the true one or just the false positive result. This for the fusion analyze. And this is for the DNA template. And the RNA will be a little different, because on RNA, besides with fusion, we can also check with the RNA expression level. And this slide show you about some analyzed results for the CNV detection. Actually, our software has set the threshold for the CNV. How we can, because we see the common copy number will be 2. So how we can believe that this kind of the copy number variation will be the true positive or not? Actually, we have set the threshold for the deletion. It will 1.2. The copy number will be 1.2, and for the amplification, the threshold will we say the copy number will be 3.6, and then you can check with the CNV information, detailed information below, and actually we will also show the phenotype related to a different kind of CNV information, and it will be related to some kind of phenotype. We will just do a very clear and detailed interpretation here, and if there is this kind of CNV is not related to the phenotype, we just said no here. So this is some the information about the panel, and also the NGS workflow about the panel, and also about our analyzed software. Thank you for listening.
Thank you, Dr. Yang Chen. Thank you both Dr. Li Xianying and Dr. Yang Chen for presenting with exceptional clarity and clinical relevance. We will now open the floor for 30-minute question and answer sessions. I would like to invite Dr. Li Xianying to the stage. This is your opportunity to pose diagnostic questions, seek clarification, and engage directly with two leaders in our field. So if you have questions, just raise your hand and the committee will give you the mic. Then please tell us to whom you address your questions.
Okay, thank you for the opportunity. Good morning. Good afternoon. I would like to introduce myself first. I am Bunga, Technical Research in Biomedical Laboratory, Faculty of Medicine of Brawijaya. I would like to ask to Dr. Lee Siri about in case where the morphology of your samples from flow cytometry, from fish and NGS provide partially insignificant result. What is your practical approach to integrating these findings to establish the most accurate diagnostic to the patients? That is my first question. And then my second question is to Dr. Yanchen. It's technical in laboratory about the integrity of the samples. What are the most critical pre-analytical and analytical factors that can affect the reliability of the NGS result in hematopoietic malignancies? That's my questions. Thank you. Okay, thank you for your question. So just let me repeat the question. So you're asking which is the most useful type of test, or for the therapy approach, if you have only insignificant result from the morphology and the flow cytometry and fish, what is your practical approach to determine which is the case of the patients for the diagnosis? Oh, I see. You are saying if there is a discrepancy. Okay, different for the insignificant results. So you already mentioned that you have the morphology of the cells and the flow cytometry. Yes. And it's the result is slightly insignificant. So the morphology said this, the flow cyto said otherwise. Discrepancy. Yeah. Discrepancy. I think it's quite important. So I think as an end, because when we analyze the sample, we use different methods. So usually what we do in our center is that there is what we call the integrated report, meaning to say that the pathologist or the clinical pathologist will actually look at all this and come up with a conclusion. So we have to determine what is more specific to the case and your quality control and understanding the limitations and of each of the different tests. The limitations. So limitations meaning to say what is more specific. So for example, if the morphology says that this look like blastoid, then you have to kind of, as a specialist in clinical pathology, you understand what are the different conditions that can give rise to an appearance like that. And then you look at the flow cytometry, and then you look at your markers. Usually for flow cytometry, the more markers are consistent, the more likely it is to be believable. So it really takes some experience to say that which is the true result. Yeah. Okay. Thank you. Does that answer your question? Thank you. Okay. Take your answer first.
Okay, thank you for your question. So I need to confirm with you. You want to check with what kind of the important things will affect the final result with the wet lab. Okay. So actually, because we need to check with the sequence evaluation from the initial sample. So first one, for the sample itself, the sample quantity will be very important, because if the sample quantity is very low and maybe a lot of initial information are just being lost, so maybe just the initial information cannot get so many effective information. This is the first one. And after we collect the initial information, we need to protect the library extraction. So also we need to ensure that the extraction kit can give you the the nucleic acid with high quantity, get enough and get to make sure the when we perform the extraction, the DNA, the nucleic acid won't be damaged in this step. This is the second one. And also for the library preparation, we need to make sure that we want most of the initial fragment can be at the barcode for the following hybridization step. So because we want to have the high library rate, conduction rate, we need to make sure that the fragment. So we need to make the fragment within the suitable region, like the 200 BP to 300 BP. So with the region, the ligation rate will be higher compared to other smaller or large fragment.
So first, you need to make sure that you have a high purity sample solution.
Make sure if we can make sure of that, and because we need to check with the somatic mutation. So if the tumor proportion, we need also have requirement for the tumor proportion, the purity of the tumor, And then beside for we said about the library preparation, we want to a lot of initial fragment can add the barcode. And then for the hybridization, actually, it was a very important step actually for the NGS, because if there's something wrong with the NGS hybridization step, maybe the capture uniformity, the on-target rate will be affected, and maybe some region cannot get effective sequencing depth. So maybe the result can be not reliable, because as I said, we recommend like the effective 1,000 times sequencing depth. And if something wrong with the watch step with the hybridization, maybe a lot of the off-target region and also some the on-target region have some lose of the target fragment, and the sequencing depth will be decreased, and we cannot get in. So I think it's a little complex with the NGS workflow, and we can provide you with the Lotus and a lot of tips to help you to perform good with the wet lab actually. Thank you.
Thank you, Dr. Yanjing and Dr. Leslie, for the answer. I'm very pleased. Thank you for the answer.
Any other questions?
I actually have a question for Dr. Yang. So you mentioned about the copy number variation analysis. Is that routinely part of the analysis? And are you referring to all the chromosomes or only the specific genes of the chromosome? How do you piece together the information?
So because just as I said, also have some kind of database, and guideline has seen maybe this kind of the genes copy number variation will plays a very important role in such kind of the progress of the blood cancer type. So actually, when we develop the panel, we selected the specific genes, and but actually, for the CNV detection, if we have the prop here, the CNV can be detected actually, and the CNV detection will also be a little different from the furin, or different from the SMT or the indel, because for the CNV detection analysis, we need to depends on the sequencing depth. So actually, we need to use some of the sample to build a baseline. So when we analyze the results, first we have the usual, and then when we check with whether it will have we need to based on the baseline to check whether it will be the true CNV or not. Yeah.
More questions?
Yeah. Thank you, Dr. Tina. My name is Hayati, and I'm a clinical pathologist resident. And I would like to ask to Dr. Lisi Ying, if laboratory can only afford one tier of testing, NCML, what is the minimum gene set that change management the most? And what would you sacrifice first? Thank you, Doc. Yeah, okay. Thanks for the question. So what you're trying to ask is if you only have one test to do for CML, what would you do? Is that right? Yes. Yeah. I would actually do the PCR. Yeah. I think the PCR is more sensitive and then it captures the vast majority of the tests, of the cases. It's technically speaking not too difficult to perform, especially at diagnosis because your depth doesn't have to be very deep because it's very high percentage of the cells. Yeah. How about like the one who is actually show essential thrombocytopenia look alike before and the other genes that you explained before? If we could only choose one tier of gene set, which one we should use? We can. So your question is specifically for the essential thrombocythemia? Yes. So we need to say, for example, if the patient presents with a very high platelet count. Yes. And you want to make a diagnosis. Yes. Am I right? Yes. Yeah. I think essentially, so if we are really trying to drill down on what when we don't want to over investigate, I would say that a bone marrow test would be very helpful. For the classic ET, the bone marrow is normal cellular. Myeloid cells are not increased, and you have just the megakaryocytes that are increased and hyperlobated. Whereas for CML, it's usually hypercellular. The megakaryocytes are smaller, so you can already differentiate what it is likely to be. And then if you see that the morphology is more maybe suspect CML, then you do the PCR for the PCR evil. If it's more likely to be ET, then you can either, if it's so classical and there's no secondary cause, you might actually just stop there. If you want, then you can do your JAK2 because JAK2 is most common. But if you find that JAK2 is negative, and then your question will be, do I need to do the CAR-L or MPL? I would say if cause is an issue, you probably do not need it. If your morphology is very classical and you are quite confident of the morphology, then you probably don't need to extend all those minor mutations. Does that help?
Good. Thank you, Dr. Yang. Any other question? If not, I do have question. So, for the Lee, you said that the TP53 mutation is the one with the poor prognosis, right? But if we don't have the NGS, is it possible to replace that with the karyotyping or other diagnostic tools?
And so, yes, absolutely. So the TP53 mutations, they are typically, firstly, the context. So maybe therapy related. So previous chemotherapy, the patient received previous chemotherapy or such as that. Then number one is that the karyotype, if you get a karyotype, is typically very complex. So what we are trying to say is that how much do you need to know is this TP53 or not? Do you really need to know to manage the patient? Because it's very different. If you just want to know to classify versus know to manage the patient is very different. So usually the TP53 is associated with very complex cytogenetics, and on the karyotype, you might actually see a 17p deletion. Yeah, on the karyotype. Then beyond that, even if you know that the patient has mutated TP53, you're not going to manage the patient very differently. You might actually say that, yeah, I don't need the, to really know, is it a TP53 or not?
Okay. So is it karyotyping is enough, but then you more focus on how the to treat the patients, right?
Yes, correct. But if you happen to do the NGS, if the patient can afford it, or you are doing the NGS for other reason, you find the TP53, it just helps you to make the diagnosis. But I think it's not really necessary to really use it to treat the patient. Yeah.
Okay, understood. Okay, from the audience, is there more question? Because we still have around. Oh, we have enough. We already have enough questions. So thank you for very insightful question and answer questions. We're gonna end the guest lecture. Okay. Thank you everyone for coming. Today lecture have spent our understanding on how to use NGS and also how to incorporate like modern hematopathology technology. We hope today lecture have provided valuable insight in the evolving field of modern hematopathology. On behalf of Faculty of Medicine Universitas Brawijaya and our visiting experts, thank you for your attention and your dedications. We conclude today's guest lecture and we look forward to see you at the future educational events. Thank you.